There is a bell. I've also announced it's happening. Welcome back after that rejuvenating tea coffee break. And for our next session, I would like to invite as chairpersons Dr. V. Kannan, who's a consultant and head radiation oncology, PD Hinduja Hospital and Research Center, Mumbai. Dr. Satyakam Savaimun, who is a consultant in surgical pathology at PD Hinduja Hospital, Mumbai. I call upon the first speaker, who is Dr. Srinivas Chilukuri. He's a senior consultant radiation oncologist from Apollo Proton Cancer Center, Chennai. He will be talking on management of GG5 prostate cancer, learning from an Indian collaboration. Over to you, sir. You've got 8 + 2 minutes.
Good morning, everyone. Yesterday we heard Dr. Borges speaking about Gleason score, and with all its fallacies and weaknesses, we still use that. I mean, it's central to the most important prognostication for prostate cancers, and it was shown across several studies that patients of grade group 5 prostate cancers have inferior outcomes, and many believe that treatment intensification helps. And I'm sure most of the audience here believe that addition of surgery as part of multimodality treatment helps. But there are others who believe brachytherapy would intensify the local treatment. That could be beneficial. And some believe that we could continue giving the contemporary standards of radiation therapy doses along with long-term ADT, but do systemic therapy intensification. So how common is GG5 in the context of prostate cancers? We've seen if you count all comers, all prostate cancer in the Western setting, it could be around 5%. But if you see in the high risk, this is from the trial of 6 months versus 18 months Australian and New Zealand trial, which showed about 15 to 20% are grade group 5. But if you see the POP-RT data, you can see that about 1/4 of our patients, of high-risk patients, are indeed Gleason grade group 5. So it's not an uncommon scenario at all. So this question was came to our mind, that what are the outcomes and patterns of failure of biopsy-proven Gleason grade group 5 prostate cancers treated with contemporary radiation therapy doses and technique along with long-term ADT. So this was a multi-center effort, and many of the collaborators are in the audience today. 20 cancer centers across India had participated in this study, and radiation oncologists were personally contacted, and they were all have a track record of large experience in prostate radiation therapy. They had a dedicated oncopathology service. They have modern radiation therapy techniques at their disposal, and they were using it routinely for prostate cancers. And they were willing to contribute their data. And these are the different centers across the country which participated in this effort. And this came out as a publication recently in Clinical Oncology. And more importantly, you can see all the collaborators here from different hospitals across the country. So all patients who had non-metastatic disease, whether or not they had node-positive disease, were included, treated with definitive radiation, basically a curative doses of radiation, at least 18 months of follow-up. All of them underwent staging investigations. Most of them, of course, I'll tell you how many of them had PET, but ADT method and duration was captured, radiation dose fractionation was captured, imaging at recurrence also, what kind of imaging was done to assess to pick up a recurrence was also captured, and we anonymized data in RedCape database across these centers, and then the data was collated. The primary endpoint was MFS, and secondary endpoint was BRFS and patterns of failure and toxicities. So we had collected about, the study included about 462 patients. More importantly, 80% of them were T3 and T4. 30% were node positive, and the distribution among Gleason grade group 5 was 4+5 was seen in about 60%, and 5+4 and 5+5, the primary Gleason 5 was seen in about 40-45% of patients. The TURP before radiation, about 33%. 1/3 of them underwent TURP before radiation, which is probably reflective of our practice in the country. 80% underwent medical castration. Of median ADT duration was about 2 years. As you can see, almost everyone underwent IMRT. A lot of them underwent moderate and ultra hypofractionation. PSMA PET was done in 1/3 during the staging investigations. These were the survival outcomes with a median follow-up of 56 months. 5-year MFS was about 75%. 5-year BPFS was about 73%, and OS was 90%. The 5-year prostate cancer-specific mortality was about 6%. This was the multivariate analysis. We saw that primary Gleason pattern 4 had a better outcome compared to primary Gleason pattern 5. So 4 plus 5 fared better than 5 plus 4 and 5 plus 5. Node positive fared worse compared to node negative. Castration had a better outcome as far as MFS and OS was concerned in patients, in all these patients. And you can see that the 4 versus 5, primary Gleason 4 versus primary Gleason 5, there was a clear-cut difference in the curves. We also looked at, do we need the treatment intensification with local RT? I mean, we don't know, but at least among the 115 biochemical relapses we had, and most of these biochemical relapses were imaged with PSMA PET, about 2/3, 3/4 of them, about 77%, and 85% of them had distant metastases. Only about 6% of patients had local only relapse, signifying that this is predominantly a cohort of patients who have systemic relapses rather than local relapses, which counter-argues the point, do they need really local treatment intensification? The toxicities were quite expected, quite low in the community setting because we were using IMRT, and all these centers were reputed centers across the country, and they were doing high volume work in general. So the strengths of the study was its first, one of its kind, I would say, multi-center collaboration for prostate cancer outcomes in India across 20 centers. All of them gave high radiation doses, near universal IMRT, hypofractionation in about 64%. PSMA PET was used in 1/3 of patients upfront and almost 80% at the recurrence. Toxicity data was also there, but of course it's a retrospective study. We did not use brachy, although most patients were not suitable for brachy. Systemic therapy intensification, now we know that abiraterone helps in node positive cohort. We didn't use that when, of course it's a retrospective study. And central path review was not possible in this particular setting. And we also compared with other studies which used similar doses and similar techniques. And despite having more advanced disease, more number of patients who had T3, T4 disease, much more inclusion of node positive disease, the outcomes were very comparable across the studies for these specified cohort of patients.
So last 1 minute.
Sure. The question is, what happens with local treatment intensification? So this study, again a multicentric study, large study, compared prostatectomy, EBRT and brachy. It showed that EBRT plus brachy was better than prostatectomy and EBRT alone. However, if they compared patients who received optimal EBRT, which is EBRT doses more than 78 gray and 24 months of ADT, there was no difference between EBRT and EBRT plus brachytherapy. Very similar outcomes shown in this study as well. Again, a large retrospective study. Basically summarizing both these studies, addition of surgery did not help. Addition of brachy, it did not help, especially if you give contemporary doses of radiation in these cohort of patients. What happens with systemic intensification? This is a Stampede trial. You can see majority of them are similar to our group of patients. Large number of node positive, large number of T3, T4, and very similar outcome, 75% MFS, just like the standard of care what we used. And addition of abiraterone gave 10% improvement. So you can see that probably that is what we can expect if we add Abi to our group of patients. So the key learnings, this is what my title is, the contemporary radiation results in better control and higher survival. Key is high dose radiation therapy, even without brachy. Primary pattern 5 showed worse outcomes, probably need to reclassify Gleason grade group 5. Patterns of failure suggest that 85% had distant metastasis, and outcomes are likely to better with systemic therapy intensification because of the distant metastases. So I would like to thank all the collaborators who are in the audience, who are not in the audience as well, and especially Dr. Vedang Murthy for leading this effort. Thank you.
We have 1 minute for discussion. One question.
Congratulations, Vedang and Srinivas. It's good to know that it's working, but don't you think, I want to ask you, why was MFS as the primary endpoint? And why not BRFS as most of the studies?
So we did evaluate BRFS as well, but MFS is more robust endpoint, which reflects the real benefit in terms of local treatments. And therefore, that is a time-tested endpoint. And therefore, we chose that as a primary endpoint, although we looked at all of them.
Yeah, I would have put the other way anyway. So you were saying that these are all high risk. You know, as soon as Robo came, we started seeing more of 9, 10, Gleason scores. We stopped seeing 7, 8. It's very rarely, in a year, we might see 5, 6. So that local treatment or local dose intensification is quite important. What is your view on this after doing this study?
So not just our study, I showed the retrospective studies also, that it is important that we go up to 80 gray, 78 to 80 gray. And that is what the studies also shown, that if you give optimal radiation with ADT, is there a benefit with brachy? We don't know. These are all retrospective studies, but this is a fact that if you give optimal doses of radiation, there is very little advantage you get with local intensification.
I have two observations on your study. One is that 33% of the patient had a TURP.
Yes.
And now as a local therapy, I have read in the literature from Japan, paper have been published, we call it a cytoreductive bipolar TURP. And this is our practice, patients who have LUTs and enlarged prostate, and we like to do cytoreductive TURP followed by all other treatment what you have suggested. And in your series also you have mentioned, so can you do a subgroup analysis of this 33%? Is there any difference in the outcome or not? The second point is you have mentioned about the orchidectomy. The group has a better survival. So can you also look into that? Because is that the advice now to do a orchidectomy or in front and then you proceed with all kind of treatment?
So both points.
Be very quick with your answers.
Yes. Number one, TURP, we looked at it and we didn't find any difference in outcomes. But TURP obviously is normally associated, one would expect that higher rates of GU toxicities, which we didn't see in this particular group of patients. So the second question is regarding the orchidectomy, not just us, not just this study, but there are others as well from India, as well as from other retrospective studies, which showed that castration probably had better outcomes in these cohort of patients, probably reflective of longer-term ADT rather than anything else. So yes, that is something which we need to still evaluate.
Thank you, Dr. Srinivas Chilukuri.
Thank you.
We now have a case-based discussion on urothelial bladder carcinoma. And as moderator, I would like to call upon Dr. Bhalachandra Kashyapi, who is a senior consultant uro-oncologist at Deenanath Mangeshkar Hospital, Pune. I would also like to invite all the panelists, Dr. Uday Pratap Singh, who is a professor in urology at SGPGI Lucknow, Dr. Ravi Chandan K, who is a consultant uro-oncologist from Apollo Cancer Center, Bangalore, Dr. Suman Malik, who is a clinical director and head radiation oncology at Narayan Super Speciality Hospital, Kolkata, Dr. Amit Rautan, who is a consultant medical oncologist from Manipal Hospital, Bangalore, and Dr. Badrinath Koneti, who is a professor in the Department of Urology at Rush Medical College and an adjunct professor of urology at the University of Minnesota. He is also the president at Elena Health Cancer Institute, Minneapolis, and chief academic officer for Elena Health. Over to all the panelists who are here.
Yeah. Thank you very much.
So you've got 40 minutes.
Yep. I thank all my panelists and I thank the SOGO for giving me this opportunity. Let's move on to the cases. This was a 57-year-old male smoker, my surgical colleague, presented with hematuria of one episode. Ultrasound and CT showed a right posterolateral wall, 3 by 4 centimeter bladder mass. There was no hydronephrosis. A cysto-TURBT and the GA was done, showed a single large 4 centimeter papillary solid mass close to the orifice but not involved, completely resected. Separate muscle sent for a biopsy. There was another tumor found above the trigone which was also resected. The histopathology, these are the imaging. Right posterolateral wall, about 4 centimeter tumor. The histopathology was the first tumor was a T1G3 high grade. Detrusor was present, not involved. The second tumor was TAG2. Lamina propria was free. Muscle was not present in the second tumor. No other variant histology. as a standard, a restaging TURBT was done at 4 weeks and there was no residual tumor. So young 57-year-old smoker with a T1G3, the question is there a need for an adjuvant therapy and what would you recommend? I'll start with Dr. Uday Pratap.
Hello.
Yeah.
So if you go see that this patient falls into the high risk group actually.
Yes.
So for high risk group, he should get the intracyclic BCG for at least 1 to 3 years.
Okay, fine. Anyone else wants to differ on this? Ashwin? Dr. Konetti? Any different in the adjuvant therapy? That is the question.
But before we go to
Yeah.
before we go to adjuvant therapy, I just had a question about did any random biopsies done?
No random biopsies. The rest of the bladder was clean.
So no evidence of CIS,
No.
at least as far as we know.
Its cytology was also negative, sir.
It was negative. With T1G3,
Yeah.
cytology was negative. So that's a concern, right? So
Yeah.
now you don't know how to monitor this patient afterwards. The other question is, any lymphovascular invasion on the TUR specimen?
No, sir.
Then I think what you're saying makes a lot of sense. I agree that
Fine.
BCG would be the next step.
So he was discussed about the BCG, but he is very reluctant to take the BCG because of the side effects and the toxicity. He has read about it, he's seen it being a surgical colleague, and he is refusing to take a BCG. What do we offer him now? Uday Pratap.
So standard therapy we see, this is the BCG actually.
Yeah.
So all other therapies, they are the inferior if you compare. But if he doesn't want to get it done, then we have other options, like we can give him novel therapies like gemcitabine with the
Gem-dosi, would you do you use it in your practice?
I have used it because most of the patients sometimes they have a intolerable side effects actually. So I have
So
used on those.
you're not using primarily upfront.
No.
Okay.
Right
Dr.
now.
Konetti.
I guess here, I've heard that there's a lot of issues with the Moscow strain, but in the US, for sure, we would do BCG would be standard. If need be, we can always reduce. If the toxicity is too high, it could keep going down.
So in fact, this move has come in USA only with the BCG shortages. You all people